Live in 5, 4, 3, 2, 1. We are live now.
Very good afternoon to all of my friends
Your
who
video.
are going to. Okay, just a minute. Virtual background is loading. It will be there in a. Yeah, it's there now. So, am I visible and audible?
Yes.
Yes, sir.
So, first of all, as a moderator, I like to thank Team ASSI to give us this opportunity. And as a World Endoscopic Spine Society, as an academic partner to our prestigious national spine academic body, ASSI, that this initiative, I really appreciate that whatever we are talking, discussing, and sharing our experience will be shared globally and not taking much time. I think I'll start our first presentation and briefly talking about World Endoscopic Spine Society. The World Endoscopic Spine Society was formed somewhere in year, I think, around 2009. And the main vision of the society was to promote minimal invasive spine techniques, which are patient-friendly and, of course, surgeon-friendly also. And we started our journey with Destandau Endospine. That was the time when that was a technique which has come in, and many surgeons had shown interest in this technique. From, I think, that time onwards, now we have many spine endoscopic techniques and other minimal invasive techniques also, which have made the difference in outcome of spine procedures or spine surgeries. And we now are talking about not only about discs and decompressions, we have gone much beyond. We have pushed the envelope further, and we are talking about now endoscopic assisted fusions also. Like UB is a big player nowadays, where you are able to do your fusions also. Similarly, there are other techniques, so-called, I think Rio company and some other companies who have come out with the tube-related endoscopic assisted fusions. So I think it's a very, very enjoyable journey. As far as I can share about myself, that in 2002, I ventured into field of spine endoscopy, and I am still enjoying my surgical practice or spine endoscopic practice, and not. So this is what Endoscopic Spine Society is about. We are here to promote these techniques for surgeons, for the benefit of patients. And we, every year, we conduct regular endoscopic spine courses for the benefit of our younger generations. And I'm sure the philosophy is now almost, it's a wave now. Every surgeon wants that they should learn these procedures and pass on the benefit to their patients. So this is briefly about our society. And now may I request Dr. Atman from Indonesia to kickstart his presentation. Over to Dr. Atman.
Before that, I would like to say something on behalf of our ASSI, Association of Spine Surgeons of India, and the Bombay Spine Society. I'm the president of the Bombay Spine Society, and we are the host society. And in order to give a wider range to our annual conference, ASICON 2024, we thought of encompassing all the different societies world over, one of them being the World Endoscopic Spine Society, to expand the horizons of knowledge sharing, because we are going to record this, and this will be telecast in our conference for the benefit of all the registrants and all the delegates. So this is, in other words, this is an ASICON even before the actual ASICON has started. It's just like 6 weeks before, and we are already into ASICON. And this exciting area of endoscopy spine surgery is really enigmatic and very attractive, a proposition with the patients calling it a keyhole surgery, and definitely has plenty of benefits to the overall outcome of the surgeries. So I welcome all the faculties who are participating in this meeting to deliver their knowledge to us. And on behalf of the Bombay Spine Society and ASSI, we're very thankful to all the delegates who have taken out time to participate and give their knowledge to all the delegates of the conference. This is being telecast live, and there are probably a lot of other viewers on the Ortho TV and all that. Plus, it is going to be in the conference, so it will be huge coverage and huge benefit to all the interested people. So, without going any further, I request the next speaker, Dr. Atman, please can start his deliver his lecture. Thank you.
Thank you, sir, for your speech. Hello, my name is Dr. Atman. I am from Indonesia, and I would like to share my experience with Destandau. Okay, share the screen. Okay, can you see my presentation? Okay.
Yes.
Yeah.
Yes.
Okay. Destandau is also known as a microendoscopic discectomy. And I would like to speak a bit about my technical considerations. And next. Okay. Actually, first, I studied the Destandau technique in 2018 in Bordeaux, teach by Dr. Destandau himself and Dr. Marjory. And I met many friends from India, Dr. Mohinder and Dr. Srivastava also. And we have also 4 Indonesian delegates that come to learn about the Destandau technique at the time. And because I've just started my neurosurgery practice in around 2017, so this is very a bit foreign for me. And then in 2020, I started the endoscopic transforaminal PELD Grigor. And then after that, I started I have access to Destandau's equipment. So I started doing Destandau at 2021. And then after that, at September 2022, I come to Dr. Mohinder's lecture in Zirakpur, India, to add more knowledge about Destandau. And then, in 2022, I started doing the MMAD arthrospine duo. And then in 2023, I got into the World Congress in World Congress in Nagercoil, Kanyakumari, India. So my experience is that I have a 3-year experience with doing 28 cases with GORE, lumbar transforaminal, and then I did Destandau for 74 cases with mostly at lumbar 4 and 5, and then tried to do also arthrospine cases for about 17 cases. So the spinal stenosis is a narrowing of the spaces within the spine, which can pressure the traveling spiners, and usually occurs at the lower back spine. And also, lumbar disc herniation can pressure also the tackle sac and the roots nerves. The most etiologies are bone overgrowth, herniated disc, and then thickened ligaments, tumors, and spinal injuries. Now, Destandau technique is a visible or an operative technique to treat all those conditions. And usually the general indication is we can do the lumbar disc herniation, the central and paramedian disc herniation, also far lateral with extraforaminal trajectory. And usually if they have pain, then consistent with the radiographic findings. Usually I do the decompression for canal stenosis with a sagittal diameter less than 12 millimeters. Also, if there's a facet joint overgrowth with radiculopathy, and also if they have failed with doing non-operative treatment for at least 6 weeks. And usually I do not do that if there's a spondylolisthesis more than 4.5 millimeters or more than 15% of AP diameter. So if you want to learn more about the techniques, you don't have, you need to come and see and try, but you can get more from the videos from Dr. Rohidas, and there's a few links that you can get. So the basic equipment needed for the hospital is the C-arm, also the monitor and the bipolar machine, the suction, and a high-speed drill. Usually the drill needs at least about 7 centimeters to enter the sheet. And this is my own equipment. Usually this is what I do to have several carriages that actually fits the hole for the inner sheet. And I have a small arthroscopy monopolar. You can use the monopolar, and a small bipolar that's along with a micro bipolar, and also the set of endoscopic bipolar that was given with the set. So usually we prepare the patient in a prone position. It's better to have their legs flexed so we can have a bigger interlaminar area. And we have the incision around with the targeted to the disc about 1.5 to 2 centimeters paramedian of the medial processus spinosus. And this is for L5 and S1 incision. Usually we have to make sure the position is good enough to achieve this. And this is, for example, if I want to do 2-level with 1 incision, usually I use a needle, just a syringe needle, and to make sure that those different in 2 centimeters difference can achieve the L4 and 5, and it could achieve the L5 S1. And don't forget that if we want to do the first anesthetic, you also need to have a good pHACKine, or usually a lidocaine and adrenaline combination. It's very important because of that. When we do the muscle dissection and retraction, there will be not much bleeding. First, after the incision, we put the dilator, and then making sure the dilator was prone up and down and left and right, and then we can put the outer sheet, and then when the outer sheet is there, we pull up the dilator, and then we do the muscle dissection. It's very important to make sure the muscle dissection is good enough so we can see a clear view of the lamina. When we can have a good clear view of the inferior lamina, then we put on the inner sheet. Usually, sometimes when I see the inner lamina to make sure we are at the right spot, we can do another C-arm. So when I started the technique, usually it takes me around 4 to 5 hours to do 1 level and making sure that everything is okay. But nowadays, I can do it in less than 2 hours. And this is the positioning if you want to do the ipsilateral laminotomy. And also we can do undercutting to the contralateral laminotomy. As you can see, this is an example of a post-operative MRI where I did also the contralateral area. I do some undercutting to achieve the contralateral area. And then after that, we do the laminotomy. Laminotomy usually from the spinal laminar junction, and then I go to the contralateral and then go to the lamina inferior, and then go to the lamina superior, and then I go to the lateral side. Usually I put the lateral side last because usually the bleeding is over there, so it's better to do most of the bony works and then do the area where it's possible to have a lot of bleeding, and do the flavectomy. If we do the inferior lamina good enough, for about 1 centimeters, we can achieve the detachment of the flavum easily. And after that, this is an example of retraction from the contralateral side, and you can see the midline, and then you can see the ipsilateral. And then after that, usually I use the retractor to push to achieve the area of the disc that I want to excise. And sometimes we could use the simple knife, number 50 knife. And also, if you have a practice with eye specialist, sometimes I use a keratom knife. It's sharp and it's easy, and it could enter the sheet good enough. And then after that, we do the excision, and usually I take around 1 or 2 centimeters of the what do you call it? The alligator, yeah, the alligator. And after achieving a good decompression, usually I continue with flushing to make sure there is no remnant. And then lastly, we do a nucleoplasty with the bipolar so that we hope there will be no more remnant that's go out. And lastly, usually I put some gel foam and did a good stitching. And sometimes, if I'm not sure, I do a subcuticular and then continued with a vertical mattress. Okay, this is some of the cases that I've done. This is one of them. Is a female 25 years old with left myeloradiculopathy. Interesting part is this have a center of herniation. I perform partial hemilanotomy to the L4 and 5. As you can see, this is the condition after there is a good decompression of the contralateral side. And then there's a good, after excising the disc from the ipsilateral side. And this is the post-operative MRI, as you can see, with there's a slight hyperinstance in T2 of the disc, and usually it is filled with blood. So the only problem is due to long retraction, there's a post-operative numbness. But usually it lasts around 3 to 6 months. There's also a female, 38 years old, with a myeloradiculopathy of the L4 and 5. And you can see there's a disc herniation of the paramedian side of the left side. Also do hemilimanotomy and flavectomy. And as you can see, the post-operative MRI with good decompression, and this is okay. The pain was reduced to 3 in 2 weeks. And for L5 and S1 radiculopathy, usually the trajectory is a bit, what do you call it, angled. So the hard part of doing the angle is sometimes the carrison that you use can hit other parts of the body or other equipment. But we can do it, and as you can see, we did a partial hemilaminotomy, flavectomy, and discectomy. The pain is decreased in 9:1, but with numbness of the left lower limb more prominent. The problem with me doing the Destandau is sometimes I'm not so sure if the disc is so clear. So I tend to use retractors long for a longer duration time. So sometimes it became a numbness of the left lower limb. And this is also a female, 40 years old, with left radiculopathy L5 and S1. As you can see, there's a central disc herniation. We did hemilaminectomy and flavectomy and discectomy. The radiculopathy goes from 8 to 1. And as you can see, this is the middle photo is the MRI of the postoperative day 1 or 2. You can see there's a hyperintense, usually filled with blood. And then after 3 months, this is the postoperative MRI after 3 months. There's the good overgrowth that can have, and the patient have reduced radiculopathy of pain. And then this is also a female farmer, 64 years old, with bilateral myeloradiculopathy of L3 to L5. I did 2 levels of the L3-4 and L4-5. And for 2 hours and 12 minutes, I did a decompression and do a discectomy. And as you can see, the post-operative MRI, the post-operative MRI is not here yet, but we did 2 levels, and the patient did very happy because the pain is myelopathy is decreased to 2 and the radiculopathy is decreased to 1. So after all those experience, what also happened is the complications. I have all those cases. I have 4, 5 dural tears that created a CSF leak. Usually in intraoperative, I put gel foam or fibrin glue, and once I tried a muscle patch and cauterized the durameter. For some people, they also use gel foam and suture, and dural clip, but I have no experience to do that. And usually I give acetazolamide and bed rest for at least 2 weeks to 1 month. And another note that I found from the journal, sometimes it's hard to make sure the bandage is pressured for the patient. So sometimes I put a bandage and suture the bandage to the skin, so that make sure that there's no dead space. After a week, usually I resuture, and then after 2 weeks, making sure there is no more leak, I take it all out. And also postoperative numbness or weakness for 30% of the cases, usually due to the long retraction duration. And if you get better in doing the Destandau, you can try to reduce the retraction usage. But sometimes if the area is bleeding, sometimes I'm not sure whether I can rip the root of the dura. And I also use postoperative methylprednisolone and do electromyography to make sure that there is only a decrease in amplitudo or there is no active denervation. And most of the time, the prognostic value of the electromyography is good. There's also a problem with reherniation. Luckily, on all my cases, there is no reherniation. But to make sure that that doesn't happen, Usually we can do intraoperative flushing and nucleoplasty by cauterizing the intradiscal. And in US they use barricade to make sure there's no reherniation, but I have no experience and access. And then I usually to make sure the patient heal the annulus for quite the capsule for good. Usually I ask for the patient to have a post-operative corset for at least 3 months and to restrict high impact physical activities. And so also there's a problem with infection. I have like 3 cases with infection. And usually to confirm, we can do MRI post-contrast, or you can use the DVI sequence when you see there's a increase in hyperintense in DVI. It's highly possible it is an infection. And I usually use antibiotics for infection. And if it doesn't work for 1-2 weeks and the patient claim for that they have a problem with the motoric or sensoric, then I reopen the patient. I have one case that I had to do a reopen because the abscess make the patient weakness. And after that, the next for the MMED is the arthrospine. I try to use it. And I use it for the cervical 4 cases. This is an example of the case for the cervical of the left. I do hemilaminotomy and flavum excision and use a drainage to make sure there is no bleeding. And also did a case for post-operative schwannoma. I used the small incision for the arthroscopy to make sure and give more fibrin glue and then do a pressure bandage. It's good. The patient motoric is better in 6 months after operation. So what is the strength of Destandau? Compared with open surgery, it is very good minimal incision, less tissue and bone trauma. And also optimize the compression sparing of the spine structure, and mostly we can reduce the eye strain and neck strain for operator. It's easier to convert from microdiscectomy because we don't need to learn about triangulation, less blood loss, and of course for me, doing Destandau has the least investment to start the practice. And then for compared with best, the strength is less water usage. So we rarely have water-related complications, and I don't have need to buy or equipment of the radiofrequency, and the bleeding can be characterized or tamponade with surgical or cottonoids. Compared with transforaminal endoscopy, there is very less X-ray exposure. Now I only use like 4 X-rays and use it for just to make sure I'm in the right path for every operation for one level. We have access to flavum, and which usually transforaminal endoscopy could not achieve, and obviously less investment. The weakness compared with best is maybe to achieve clear view, we need more muscle bleeding cauterization, more bone trauma, and more multividus muscle detachment. And sometimes I could do over retraction of fluid, so there's a nerve damage. And for some patients, 2 centimeters is still big, and some equipment does not fit the 1 centimeter diameter of the working channel image. So that is my presentation. Thank you.
Yeah, Dr. Dhira, thank you very much for your presentation about Destandau technique and then your experience with the arthrospine. I think the next speaker will be, I'll request now Dr. Mukul to have a case presentation. So over to Dr. Mukul Kaushal.
Thank you. I'm sharing my screen, and I take this opportunity to thank ASSI and Wess to allow me an opportunity to present a case. I'll be talking about arthrospine duo cum UB assisted unilateral laminotomy for a bilateral decompression. So unilateral laminotomy and bilateral decompression, it is basically a minimally invasive concept where it can be achieved through microscope, through dry endoscope, or through wet endoscopic techniques. So I'll just talk a bit about the system, the arthrospine duo system, which we are using. It's an indigenous design system It can be used in both dry mode as a Destandeau based technique, or in saline mode like a PSLD based technique. It is compatible with both 0 and 30-degree based telescopes. The scope can be advanced beyond the tube, and we can even use the tube to create another portal and use it to convert to a biportal UBE technique. So this is the small assembly. There's a couple of dilators, serial dilators. There's a tube and a couple of inserts. One is used for the dry mode and the other is used for a saline mode. So the dry mode is just like a microscopic concept, and the anatomy and appearance is similar like a Destandau mobile operating tube. The saline mode, we tend to use it when we are working more closer to the dura once we have removed the phlegm, and we ensure that a continuous saline inflow and outflow assures a constant hydrostatic pressure at the surgical target. And this continuous fluid irrigation allows a very clear and enhanced field of view. And this is quite comfortable for surgeons who are already doing arthroscopy of the joints or doing a PSLD based endoscopic technique. And if you want to switch to a UB with the help of this tube, like on this bone metal, once the tube is resting over the interlaminar window, we can just create a stab incision. And through that stab incision, we can introduce this straight rod. It hits the tube subfacially and lands over the lamina. Over that, we can introduce our telescope sheath. The rod comes out. We connect our camera to this telescopic sheath. The tube comes out. So it becomes basically a biportal technique. Now it's become a semi-tubular. It's become a tubeless technique now, and we can switch to a UB technique where every instrument and camera is now freehand mobility is assured. So coming on to the case, it's a 44-year-old male. He has symptoms almost from the past 3 months, which have worsened from the past 1 month. His mainly complaint is low backache with radiation to the left side. His nerve root tension signs are positive at 50 degree. He's unable to wheel walk, so he's developing a kind of a foot drop. So this is the MRI. So we can appreciate on the sagittal cuts that the 5S1 disc height has settled, but there's a 4-5 pathology quite significant. There seems to be an up-migrated disc more towards the left side, which is the cause of his foot drop. But on studying the axial MRI carefully, we can see that there is some amount of recessed stenosis, and there is some disc material on the right side also, but he's asymptomatic on the right side. So the diagnosis of a PIVD L45 up-migrated with left side partial foot drop was kept. We plan to approach from the symptomatic side, plan for a fragmentary retrieval, and then do a unilateral laminotomy and a bilateral decompression to assess the opposite side disc and recess. So the patient is usually put prone on bolsters with maintaining a neutral lordosis. This is done under spinal anesthesia. We give a 10 millimeter skin incision, which is about 5 to 10 millimeters paramedian on the symptomatic side through the skin and the fascia. Then blunt dissection is done up to the bone and interlaminar window with the passage of serial dilators of 5 and 10 millimeters. And then the tube is slid over this second dilator, and a level check is done under a lateral CCTV image. And once the endoscope is connected, this is the inside picture. In the dry mode, to expose the lamina, we put in a soft patty. So this is a left-sided L45 approach. 9 o'clock is the cranial end, and 3 o'clock is the caudal end. 6 o'clock is the facet side. So initially we start with burring at the base of the spinolaminar junction. This is a burr which is commonly used in our joint knee arthroscopy, shoulder arthroscopy. After the lamina has been thinned, we can take bites with the kerrison, which exposes the ligamentum flavum underneath. And laminotomy is performed till the cranial lamina flavum attachment is detached and the epidural flat starts coming into the picture. Now we are burring the base of the spinous process so that we can expose the opposite side also. A ball tip probe is quite helpful. It acts like a finger and helps to detach and mobilize the flavum. And then we put in a patty between the dura and the flavum to create a more safety channel for us. And then piecemeal, we are removing the ligamentum flavum. once the lateral border of the root is exposed, we can attempt to dislocate that fragment. But here I'm quite unsuccessful, so I remove more of the cranial lamina to create more working space cranially. And I've advanced my endoscope further down, which gives me better appreciation of tissue clarity. And now I'm trying to remove the fragment. It's quite a big fragment. Here I had to keep the tube in place, but I had to remove the entire assembly because the fragment was quite big and not coming in. So the entire tube had to be removed to get this fragment out. And that's the fragment which came out in one single piece, the applied on the left side. After that, I've converted to a saline system, which makes me go advance my tube telescope beyond the tube. So this is the midline. So I'm putting a patty on the opposite side to create a cleavage plane between the flavum and the dura. Now I'm bluntly detaching the flavum on the opposite side. And under quite clear vision, we can remove the flavum to do a decompression on the opposite side. And even we can use this system to convert to a UB mode. Here I am putting in a tube, this switching stick, which lands over the lamina. And then I railroad my sheath, and then now this is a freehand technique. There I can see that that's the opposite side recess. That's my disc on the opposite side. The traversing route is at the 4-5 o'clock position. So it seems to me like a stable disc. So I'll just remove some amount of, I'm palpating the disc, seems to be stable. And then I'll just do some more contralateral flavectomy to open up the recess further. And once the decompression is completed, this is the last picture where the neural elements are quite nicely decompressed. And this is the walking video of the patient. He's quite comfortable. He's from a rural background and quite comfortable in his daily activities. So I thank you very much for a patient listening.
Thank you, Dr. Mukul. And I think Dr. PC is connected with us. PC, are you there?
Yes.
Yeah, welcome.
Yeah.
तुम अपने गांव नहीं गए विलेज?
नहीं आज कैंसिल हो गया, कल सुबह जाऊंगा।
तुम तो रोहिदास के साथ 3D डेमो कर रहे हो वहाँ 4K।
हाँ हो गया, वो सुबह एक केस था, हो गया। उसके बाद रोहिदास चला गया कॉन्फ्रेंस के लिए।
अच्छा अच्छा।
He's in a neuro surgery conference today in Bhubaneswar.
हाँ तुमने बताया था मुझे। So good. I think Atman has done a nice presentation. Mukul has done a case presentation.
Yeah, very good.
And Dr. Iside, now over to you.
Okay.
Please
So
start your presentation.
this is my turn. Okay. So I have to share the screen.
Yeah.
Okay. This is share the screen. That is application of Destandau technique. Okay. Are you able to see my slides?
Yes.
Okay. Are you able to see my slides?
Yeah.
Okay. So
Yes, sir.
my topic is the application. Should I start?
Yes, please go ahead.
Yeah, applications of the Destandau technique for the challenging situations. So this is a mobile operating tube for the treatment of the central to far lateral disc herniation and bilateral lumbar canal decompression by a unilateral approach. And this is the interlaminar window approach, and most of the time we are doing the same. Only for the extraforaminal disc, we are approaching at the extraforaminal area, that is directly extraforaminal, or maybe you can say the lateral to the isthmus or pars. Otherwise, most of the time we are in the interlaminar. And for the stenosis, we go below the spinous process over the top and go to the opposite side. And it needs only few instruments, about 10 instruments, and both the hand of the surgeons are free. It's a docking and without any fixation technique. No need to any special device to fix it. The left hand is for the suction tip and right hand for the operating instrument. The instrument is very stable here. And then the special situation, sometimes this is the commonest complication. We spine surgeons are used to face this type of the dural tear with the nerve root herniation. We used to put a muscle patch, and over that with the surgical, or nowadays we are putting the Duragen. Duragen is working very nicely. Even it's far better than the surgical and very sticking capacity. So this is a patient of 52 years lady. After 7 years of the patients had a fixation of 4-5, she developed the disc herniation at the adjacent level, that is L5S1, and extruded and migrated, and it was the severe pain and excruciating pain. This is the right approach, and this is the caudal, cranial, caudal, and midline and lateral, L5S1, and this is the nerve root. After the decompressions of the nerve root, we remove the SAP, and then this is the huge extruded disc, and it was a little bit adherent also. We detached with the help of the painful retractor and remove in total. And after that, we entered into the disc space. There was a small free fragments was left out. That also removed. Irrigation with the normal saline and gentamicin. And it takes about 20-25 minutes surgery, very fast. And then next day morning is more comfortable patient. There is no neurological deficit. Now this is a very special situation. Is a patient of L1, L2 extruded and upward migrated disc. It is a very higher level of the lumbar, that is L1, L2, and extruded and migrated almost one level above. It almost covers the L1 posterior aspect, all the whole vertebra, the about 1 and 1.5 inch gone up. And this is the situation where we used to remove the little bit of a bone on the left side, and it is a left approach. So cranially, the lamina we have to sacrifice little more. We used to remove 5 to 6 millimeter, but here maybe 2/3 of the lamina is removed, and the exciting nerve root is visible here. The exciting nerve root and traversing nerve root both are visible, and then we removed. The video quality is a little less because it is my initial phase of my practice. So it was a single chip camera. So we removed the small fragment that is about in toto, that is about 5 to 6 centimeter long, and then after the 4 hours of the surgery, patient is completely recovered, pain-free, and then 15 days, patient was very happy. And this is the MRI. We did the MRI to confirm that it is totally removed or not. This is the pre-op, and then this is the post-op. Post-op, the MRI shows there is complete recovery, and there is no remnant of the or not left out free fragments. Now, another patient of Basanti, 42 years, had severe radicular pain for 20 days. Similar radicular pain twice before, that is 2 years and 9.5 years back. So twice the similar attack, but she was improved with the conservative treatment, but severe pain for last 20 days. This is the excruciating pain, and we got the MRI. It is extruded and migrated L4, L5, it gets downwards. It is almost covered the 50% of the L5 vertebra and gone downwards, and it is in the left side. So it is compressing to the left side nerve root, excruciating pain and severe pain. Patient was crying, and there are a lot of scoliosis. There is no bladder environment, but weakness, numbness, tingling. And then we did the surgery at L4, L5. And this is the left side approach. Very small video you can enjoy. This is the cranial petty here and caudal petty. We have removed a bit of bone from the caudal lamina because it is extruded and migrated with downward. So we have removed, and the foraminectomy is adequately done, and the nerve root was almost lax free, and below that is a huge disc extruded and migrated. So that we have removed. Now the patient next day morning was very happy. She is from the West Bengal, Odisha West Bengal border. She is speaking that I am very happy that. Now another lady is the 52 years with a hard disc, and That was we used the osteodome here. There's the technique I just wanted to show you. This is the hard disk, and the very difficult to introduce the, it's a very small video you can enjoy. This is the, my 11 number blade is not able to negotiate or cut the annulus because, and also the disc forceps also failed to enter. Then we have used the Ketan punch. This is the same Ketan punch we are using, the 3 millimeter, and sometimes 2 millimeter also. And then after the removal of the hard disk, the part of the annulus, we can enter into the inside and with the help of disc forceps and remove the disc material. So this is the hard disk, how to do it. So another patient was 56 years old male patient having the left more than right pain, left side pain, severe pain, and Kaushal equina syndrome type of pain. He had a similar attack 12 months before, and then 3 months after the bladder involvement was not there. With bladder involvement symptoms, Kaushal equina syndrome, and patient was not able to walk more than 1 or 2 minutes, severe pain. And also he was standing with the support. This is the L4, L5 disc, and he has some congenital anomaly of the 2-3 vertebra. It is fused. There is no disc space, and this is a disc herniation at L4, L5, extruded and bit downward migrated. And you can see this. There is a hard disc in the right side, but the patient complained more on the left side. The hard disc is on the right side. We approached from the left side because the patient complaint was on the left side more. So we first done the discectomy from the left side, decompressed, and over the top we went to the opposite side, decompression of the opposite side nerve root, and then we traced that the hard arm, or you can say hard disc, and we have released from all around with the Ketan punch. At the end, with the help of the disc forceps, we remove that hard disc from the opposite side over the top. It is a huge, hard, calcified disc, and then we saw from the left side. This is from the left side, nerve root decompressed. This is the opposite side from where the heart is removed, and then irrigation with the normal saline. And next day morning, the patient is walking in the corridor of the hospital without any sign of the pain in his face. Now, 33 years male patient complains of the 9 months of right reticular, similar attack 6 years back, and the 6 years back, and the 2 years back, improved with the conservative treatment. And he had the 3-level stenosis, disc, 3 level. This is a 3, 4, 4, 5, 5S1, 3, 4 left side, 4, 5 left side, and 5S1 in the right side. So he approached accordingly, 3, 4, 4, 5 from the left side, and 5S1 from the right side. I'm not going to the detail of the video. Now come to recurrent disc herniation. Recurrent disc herniation is the most common complication after the lumbar discectomy. The reherniation is the commonest complication. The major issue of the revision surgery is the scar, and complication is 3 to 5 times higher, mostly the dural tear and the nerve root injury. The fractures, majority of the surgeons prefer standard open microdiscectomy for recurrences because wider exposure would be justified for less neural damage, which may lead to again instability and for the fusion surgery. But in endoscopic spine surgery, we mostly do the mobile operating tube, so panoramic view could be obtained and provides the clear differentiation of the neural structure from the scar tissue. Adhesive lysis performed while preserving the stability and the remnant facet joints, and could do the upward and migrated disc, downward migrated disc, central disc, lateral canal stenosis, L5S1 level, without any hindrance for the approach, like the other people, they faces the high iliac crest, but here there is nothing. Most important is they could avoid the unnecessary fusion surgery. Patient positioning in the knee chest position, which increases the interlaminar space by distraction. Complete relaxation of the abdomen reduces the epidural venous plexus pressure. Head and down helps to reduce the bleeding. Here is a patient of 56 years lady, decompression done in 2012. That was L4, L5, and L5S1. And you can see this is the just after the 2 years in 2014, she had this recurrence of the pain and it's crippling type of start of pain. Epidural nerve block given in 2015, and there is a 3 months of relief. Consulted many places. The mixed opinion come from the doctors. That is conservative or maybe fixation, or maybe again repeat of the nerve block. She led in the 2016 from the Bihar and Patna, and that was a wide laminectomy done L4, L5, L5S1. And then it was 2012. Now 4 years passed. After 4 years, she landed into Bhubaneswar. We did the MRI and contrast MRI, confirmed there is extruded and migrated downward disc in their L4, L5 right side. There was a L4, L5, L5S1 two-level surgery in 2012. That was index surgery. So you enjoy very small video. The trick is to have to dock the instrument on the bone, whatever the bone is left out. The lamina is not available here. So maybe sometime the facet is available or maybe the pars is available. Here there is a facet. So we removed a bit of the medial aspect of the facet and there was a cleavage. We got a cleavage between the scar tissue and the bone. After that, the nerve root was in front of us. The nerve root is retracted with the help of nerve retractor medially. And then we gradually duck and try to enter into the disc space and remove the disc. Next day morning, patient was recovered completely, very happy. The fact is, endoscopic spine surgery, the coexistence of the lateral stenosis does not affect the outcome because the bone decompression is very, very effective with this technique. At the same time, bone decompression is precise and does not lead to the higher fusion rate because we are in very much precise how much is the bone is required and adequate nerve decompression, adequate lateral or maybe the over the top decompression, everything. So after that, we very precisely do the discectomy and also the bone dissection. Now another patient of 56 male Durga, low backache with right severe radiculopathy, and it was the patient was having the first time or attack on the January 2016. That was extruded almost one level below L4, L5 and almost reached the L5S1. He was extruded and downward migrated disc. That was in January 2016. And patient is 56 years. There was a right side. You can see this is right side, L4, L5, extruded and migrated downward, one level below. There's a severe pain and patient was not able to stand even on the July 2016. After 6 months of surgery, the index surgery was in January 2016. After the 6 months on July 2016, he came to me with this situation. He was not able to stand even without support. And now it is 7 days. We did the MRI, contrast MRI, confirmed there is a extruded and migrated disc. This is a recurrent disc again. That is the same L4, L5 and right side. It is almost migrated downward. Now we can see this is a removal of the disc from the right side. L4, L5. After removal of a bit of the bone in the medial aspect of the facet, we got a cleavage between the scar tissue and the bone. And we could enter into the disc space. There is a never-ending process almost. There a lot of material has come out. So maybe you can say this is a remnant or maybe the left-out disc. So herniation of the more aggressive disc removal does not, in the reherniation, aggressive disc removal does not reduce the complications, may be detrimental to the functional segment, but complete decompression again is must to prevent the relapse. Now, next day morning, the patient was very comfortable. This was the before, and the next day morning during the round, during my visit to the room, he was very happy and he was demonstrating himself that, see, sir, I am how much I can work without pain and no issue. I have already taken my breakfast and tea. Now he was walking and showing me. In 2023, just 4 months before he came to me, it was 2016, so 7 years passed. He's very happy. And I have also operated his wife also. Both came for a checkup this 4 months before. So I did the X-ray and the MRI. And I asked him to climb my clinic staircase. He was climbing very comfortably without holding the sidebars also. And he gave a press meet with his wife. So we have done about, say, 2,800 cases. Recurrent is about 70. Open is a 58 after micro 9, and my cases that is after endoscopic surgery, 3 cases in 16 to 17 years. Now come the extraforaminal disc. Extraforaminal disc is this is a central disc or lateral disc and the foraminal disc and the extraforaminal disc. The extraforaminal disc associated with the compressions of the exciting nerve root. All other cases that is the traversing nerve root, but extraforaminal disc compressing to the exciting nerve roots, and it usually associated with intractable leg pain. In micro and tubular, the paraspinal muscle splitting technique has been used, but in Destandau, we are going for subperiosteal dissection with the help of the periosteum. Now, this is a patient of 60 years lady, occasional back pain, severe right radicular pain for 4 months, tingling and numbness up to the lower leg, and conservative treatment fails. So this is the L4, L5 right side extraforaminal disc. Here is the extraforaminal disc. Right side extraforaminal disc. Excruciating pain. And the positioning the same, localization device the same, except it is about 5 mm cranial, not in the disc space. It is about 5 mm cranial, and the approach is almost the same. This is the direct foraminal approach. We are approaching at the isthmus, not interlaminar. Is the isthmus or pars, lateral aspect of pars. So we are approaching here, docking the instrument here, and then removing a bit of the bone, the lateral aspect of the pars, and directly, always the norwood is always cranial and disc is the caudal. Operating technique, that is the same 15 to 18 mm incision, 10 mm away from the midline, but 5 mm cranial to the disc space. That is the only technique. And the depth, the instrument, and is a press fit. There is no special device that is necessary. Small video you can enjoy. This is the right approach, L4, L5, 60 years lady. So there was little bit of osteophytes, osteoporotic bone. And after the drilling, this is the disc. After removal of the intertransverse ligament, the disc is in front of you and the cranial to it is the nerve root. So here is the right approach. The nerve root is here and disc is here. Now, after discectomy, irrigation with the normal saline and gentamicin with the disc space. And this is your nerve root, just cranial to the nerve root. This is the cranial, caudal, midline, lateral, right approach, L4, L5. So this is the nerve root. Very clearly decompressed, adequately decompressed, and the patient next day morning walking without any support. There is no neurological deficit. Another patient, he is 41 years male, volleyball player, 3-level disc herniation, severe left radicular pain. Almost see the compare the thigh. The girth of the thigh is about 2 inches less on the left side. And also there is a retrolisthesis L5 is one, but it is very small and grade 1. So there is a 3-level disc herniation, 3, 4, 4, 5, 5S1. 5S1 is associated with the retrolisthesis grade 1. 3, 4 is the 3, 4, that is the 3, 4 left side extraforaminal disc. 3, 4 is the extraforaminal disc. 4, 5 is the left side again, foraminal disc. This is the foraminal disc again. And this is the central disc, L5S1 central disc again. So 4, 5, 5S1, we have given the mark at the interlaminar area. But 3, 4, that was the extraforaminal disc. We have given a mark about 5 mm cranial at the top level of the foramen. So this is the difference. We are not given marking at the interlaminar area. We are giving a mark about 5 mm cranial that is top at the foramen. 3, 4 level. Other 2 level is the same. So 3, 4, we approach from the, this is all left side. So here the isthmus and intertransverse ligament. This is the cranial, caudal, midline and lateral. The left side is the cranial because the left approach. This is the disc. After removal of the intertransverse ligament, disc is in front. 11 number blade to cut the annulus. After that, the discectomy. My patty is covering the nerve root here. The nerve root is always cranial. That is left side is cranial, left approach, and this is the nerve root. Both sides of the nerve root adequately decompressed and discectomy done. So 3 level we have operated. 4, 5, 5 is 1 is the interlaminar approach. 3, 4 is the extraforaminal approach or the isthmus approach. Now come to the over the top decompression for the LCS, lumbar canal stenosis. This is the hypertrophic facet, hypertrophic ligamentum flavum, disc herniation sometimes associated and sometimes the big osteophytes. So narrow canal. The proper diagnosis is most important. It is called the functional spinal surgery by Destandau technique, unilateral laminotomy and bilateral decompression. Remove the lesion without decompressing, without disturbing the anatomy and stability. Preservation of the motion and functions both. The indications are many and there is no contraindications. Not contraindication means the foraminal stenosis, degeneration spondylosis grade 1 also we are doing decompression. If there is a patient is stable and there is no much of the back pain, only the leg pain and radicular pain, then you think about decompression without the fixation. Multidirectional rotational angulation, scoliosis, prior surgery in the same segment and the adjacent segment also. And post-radiation stenosis, multiple level stenosis, obesity, Kodai. We do the laminotomy and non-laminectomy, trimming the bone, base from the spinal process to the facet, removal of the hypertrophic overhanging part of the facet, excision of the hypertrophic ligamentum flavum. If associated disc, but it is rare, then discectomy. This is a 4-5 disc herniation with the stenosis, and it is the young man about 46 years with approach from the, this is a small video. I'm just, So this is the discectomy we have done, and this is a left approach again. And this is my cranial, caudal, midline lateral, L4, L5. The nerve retractor protected the nerve. Post-medially, laterally, we give an incision in the 11 number with the help of the 11 number blade. And then we are going over the top to the opposite side, just removing the ligamentum flavum a bit at the midline, and also the overhanging little bit of the spinous process. And then opposite side, the hypertrophic ligamentum flavum, and then the lamina, hypertrophic part of the lamina, the hypertrophic SAP, this is the foramen. And the foraminotomy done, nerve root is completely decompressed of the right side also, over the top decompression. And this is the disc. We have given a petty on caudal, on cranial. If you need, you can remove the disc from the opposite side, but most of the time it is not necessary, very, very rare. Maybe in 1 or 2,000 cases, you will get a bilateral disc. That time you need to remove the disc from the opposite side. Otherwise, you can remove the disc from the adequately from the central disc and the far lateral disc, the lateral disc and the lateral canal stenosis, everything from the one side. If necessary, then go for bilateral. And discectomy, bilateral discectomy is very, very rare. So this is the patient. Another patient, 4-level stenosis. This is 2, 3, 3, 4, 4, 5, 5 S1. That also we are doing very regularly, approaching from the one side and going to the opposite side over the top, decompression of the bilateral. Even seizures grade 4 without any protection, so we are doing, but sometimes the petty is our help, going to the opposite side, positioning and the localization is the same. Now here is a patient of 65 years. When he approached me in 2009. That was that time he was 65 years. There was no medical comorbidity. General surgeon. He is a state government surgeon, retired that time, and presented with the gradual progressive bilateral neurologic claudication for 3 years. Walking distance was less than 200 meters. Standing time was less than 5 minutes. Best relief with the pain. Rest relief with the pain, and bilateral bladder valve involvement was not there, but there was a bilateral involvement of 3 level, 3, 4, 4, 5, and 5 S1. 3, 4, 4, 5 almost seizures grade 4, and 5 S1 is seizures grade 2. And this is the flexion extension MRI. This is the stenosis. 3, 4, 4, 5, 5 S1. 3, 4 was a severe stenosis. 4, 5 is also severe, but 5 S1 was a little less, but again, that was also severe. So conservative treatment all fails. Then injection also we thought, but he could not appreciate that. Then we thought about the decompression, and he was the chief guest for 2013 West Congress in Bhubaneswar. In 2016, after I operated in 2009, and 2013 he came as a chief guest. 2016 also we did the X-ray, MRI, and CT scan. CT scan also we did to confirm that it is a unilateral approach and bilateral decompression. So we confirmed there was no much of the osteophyte regeneration or any problem at the 3 level where operated, even the adjacent level. This is the 2020. Again, we did the X-ray and MRI to confirm. See, this is the status of the spinal cord. There is little bit of the compression at 2, 3, but 3, 4, 4, 5 S1, all the 3 level is very adequately decompressed and showing normal pressing of the spinal cord. So this is the 2020. I am following till now. He's now around 8 years now, professionally still active, mild interactive level pain. He's staying with me almost in Bhubaneswar town. So in between, sometime he's talking to me for other patients. 79 years patient, 3445 as well. Fixation, 2-level fixation in 2007, and severe buttock pain. Now bilateral for last 3 years. Son is a cardiologist. Patient want to operate by endospine technique. So this is the higher level or adjacent segment disease. It is higher level 2-3. 3445 is fixed. And there was a 3445 is fixed, adequately decompressed. Now adjacent level pathology, higher level, that is 2-3. 2-3 was very much stenosed. This is 2-3 level. And 4-5, 5S1, 3-4 is okay, 5S1 okay. But 3-4, there was a severe stenosis. So we keeping all the instruments and the fixation technique, everything is in situ. We decompressed the bilaterally over the top at the 2-3 level. See, this is the implant, this head of the rod is visible. And through that, without disturbing that, keeping intact, we could manage to decompress bilaterally. Went to the opposite side also. This is the overhanging hypertrophic part of the spinous process. I went to the opposite side. Now you can see we are going to the opposite side. Over the top decompression bilaterally. Opposite side nerve root is now visible. So nerve root up to the foramen decompressed bilaterally. This is the same side, and that was the opposite side. That we saw now. That is the opposite side. So bilateral over the top decompression and bilateral foraminotomy, nerve root decompressions without disturbing the fixation device. Next day morning, patient was very much comfortable. He's almost 80 now, 79 plus. Now this is 69 years CDMO bilateral foot drop, severe pain and burning sensation around the perineum. And patient had undergone twice surgery. The first time it was 4-5 fixation, and then there is an adjacent segment, higher level, that 3-4. So they incorporated the 3-4 again. So twice surgery done in the somewhere else, not in the Odisha. And the second surgery, during the surgery, they injured the dura. There was a nerve root injury bilateral and foot drop, and it was all mentioned in the discharge summary. Patient was crying for the surgery again because there was a adjacent level pathology, 2 level above and 1 level below. That is L1, L2, L2. This is L1, L2 stenosis, L2, L3 stenosis. Then 3-4-4-5 is fixation done, adequately decompressed. 5S1 again stenosis. So 2 level above and 1 level below the adjacent level pathology. We did all the 3 level decompression. And the next day morning, patient was very happy and walking. And I operated his wife also after 2 years. There is also 3 level stenosis. So mobilize immediately after recovering from the anesthesia, can take bath, informal dressing, physical activity as soon as possible, particularly sports, because we are not disturbing the anatomy. Anatomy is intact. So this is another patient of 32 years male, having 5S1 disc herniation, left side, L5S1 disc herniation, young man, 32 years, left side. So left approach, this is the cranial, midline, lateral, and caudal. Cranial, caudal, midline, lateral. Left side is the cranial. We have removed the superficial layer of ligamentum flavum and detaching the ligamentum flavum with the help of the Carrison punch, with the angle of the Carrison punch. Then at the midline, at 11 number, with the help of the 11 number blade, just split the ligamentum flavum, the deep layer. Then flap is separated and tilted, folded, and then the discectomy done, and we reposition the flap again. And that keeping the intact flap and depositioning after this surgery. That is the technique I wanted to show you here. So to summarize, the endospine is about 16 to 18 millimeter incision, minimal blood loss, magnified view, well illuminated view, 30 to 35 minutes max to the stenosis, 20 to 25 minutes for the disc, mobile operating tube, 3-4 level, 5 level, no issue, less collateral muscle damage, less damage to the neurovascular supply, minimal post-operative pain, rapid resumptions of the physical activity, including sports, no stitch. Patients are mobilized just after the recovery from anesthesia, maybe 4 to 6 hours, and discharged on the same or next day morning. So thank you very much. Jai Jagannath.
Thank you, PC, for nice presentation. I think now last presentation is mine. I'll try and share my screen if you can. Screen share. Just give me a second before I. Screen share new PC has.
I once said. Below green button is the sharing button. You open up your. First, you open up your presentation, minimize it.
Just a minute. Yeah. Presentation. Am I audible, PC?
Yes. Audible
visible
and your
also?
slides also visible.
So thank you, ASSI team and Bombay Orthopaedic Spine Society team for giving us opportunity to associate with the ASSI Global Program. And mine is the last presentation of this session. I will be sharing my experience on dual spine endoscopy principle and rationale. So my gratitude to our mentor and teacher, Professor Jean Destandeau. My disclosures. So why dual spine endoscopy? So the answer to this question is to incorporate advantages of both technique, dry and saline, to simplify learning while switching from dry to saline UV technique, and to aid fusion. So just to have a look on the existing posterior endoscopic techniques, we have dry techniques, we have saline techniques. You can see as the names are mentioned there. I did not read out each and every name, but one thing we must understand, techniques are evolving at a fast pace. What we are doing today may not be latest yesterday. So now talking about innovation, or you can say reinvention, let's see Destandau prototype system on extreme left top corner. This is how Destandau devised his initial endoscopic system. Then he gradually fine-tuned it, and finally on the extreme right side of the screen, you can see the finished product which we have been using in our daily practice. From here, I have taken off, and from there I first designed a first generation arthrospine system, which was a dry system. Then I modified this system. I call it second generation system, which is a dry and saline system. So there were certain issues which I'll not go into the details. Why I have to reinvent, I'll not go into the details. And for my colleagues who want to embark on journey of spine endoscopy, first and foremost important thing is to understand the philosophy and principles of various techniques, whether they are interlaminar or transforaminic. And surgeon may have to familiarize themselves with all techniques and choose the philosophy and technique that they want to embrace. Now talking about the physics of orthospine due UV system, it's a classic posterior interlaminar approach concept. Anatomy and appearance is like microscopic and endoscopic methods. And for surgeons familiar with endospine or microscopic techniques, easy to graduate. And when we switch over to saline in slide mode, it is recommended when working closer to dura. So my take is when I have exposed the ligamentum flavum, I want to do a close work to the surgical target, I switch over to a saline mode. So continuous saline inflow and outflow to ensure constant hydrostatic pressure at the surgical target. A clear and enhanced field of view is there. And this technique is surely easy for surgeons who are proficient in arthroscopy or PSLD. And the dual endoscopic spine endoscopic system is such that one can complete the procedure in dry mode, one can complete the procedure in saline mode. The choice is entirely of a surgeon. Whichever technique he is comfortable with and he has learned, he can continue with that technique to complete the surgery. So some of the issues which I have addressed in our dual this tube system, spine endoscopic system, there is a issue of triangulation when we are learning UV. Then there is a readout phenomena. There is excessive radiation when you are localizing the level, and excessive soft tissue ablation to create a dead space. Now, to minimize the learning curve, you can see this is as far as UV is concerned, this is our innovative sounding technique where we have made the learning easy. You can see here, this is a tube which is docked over the interlaminar window. Then there is a additional port is created. This is a single rod, we call it, used in shoulder arthroscopy. It is advancing towards the tube, and once it hits the tube, there is a sound, metal sound. So we call it as a sounding technique. As you can see, it is approaching the tube, and I'll show you same thing over my video also here. You can see here, once it touches the tube, the surgeon comes to know that it has hit the tube, and he's sure about the rod has landed at the right place. Then he slides the endoscopic sheath over the Bissinger rod, and Bissinger rod is withdrawn. And then he slides the endoscope and a camera, and the tube port now becomes a working port. So it is now freehand technique, and you have, this is how you use the instrument when you are doing a surgery. So indications as far as interlaminar endoscopy is concerned remains the same. Intercanalicular and extraforaminal pathology can be addressed. Now, these are the applications of arthrospine tube technique. It can be used in prolapse disc, where it is whether it is in the cervical, thoracic, or lumbar region. In all regions of spinal canal stenosis, it can be done. Endoscopic fusion and OLIF is possible. Nowadays, surgeons are doing endoscopic assisted OLIF also. Then decompression spondylolisthesis can be done, thoracoscopy, PLIF, TLIF. So there are now, these are the extended indications of this system. And this is a simple instrumentation. You can see this is a sturdy instrumentation. They are not a fine instrumentation with like other many systems where the instrumentation breakage is very, very high and instrument cost is very, very exorbitant. And this is the MIS fusion instrumentation. So just sharing with you the operative technique. This is a demo case, left-sided herniation, patient positioning. And this is how you give about 10 to 12 millimeters skin stab incision, skin and fascia, and then use a dilator 5 millimeter, then 10 millimeter, and then slide a tube over the dilator, as you can see here. And this is a dry mode, you can see here. And this is on the bone model, you can see exposure of the interlaminar window. And here you can see over the patient. And this is a exposed dura and the nerve root. And then removal of the disc. And finally, in the last picture, you can see decompressed nerve root. And in saline mode, the working insert is changed to a saline mode. And you can see here, we have to use RF to create a space here and to control the bleeding. Then you use the standard instruments to do the discectomy or a canal decompression. You can see the two layers of flavum. One is a superficial layer, two is a deep layer. Bit by bit, you remove the flavum when you're doing a canal decompression or discectomy. And you retract the dura and the nerve root and you do a discectomy procedure. Again, as you can see here, the disc is removed and the skin incision is very, very small and cosmetic. And this is you can see the extraforaminal herniation. Here you land later to the pars and you do a bone work, or you can use a burr also to expose the nerve root, retract the nerve root and do a discectomy. As you can see here, this is on the bone model. This is a exposed nerve root, and finally disc is removed and nerve root is decompressed. And this is a patient who has a instability IL-5, and this is her associated severe stenosis. And this is my earlier cases, 2015, when I was doing a dry endoscopic techniques. So I have done a good bilateral decompression, and then this I have prepared a disc bed. Finally, cage is put in, and then the monolateral fixation is done. And this patient has a follow-up now almost about, say, 8 years, 7 years, and she is doing very well. Now, this is about to share with you the up-migrated disc. Once you expose, just retract the dura and you can retrieve the fragment with help of a ball tip probe. And then you, at times, this comes out in one piece as a huge fragment. At times, it is so big that it doesn't come out through the tubes of the tube. Then you have to take out the assembly along with the disc to make it sure that you remove the whole disc. You can see the huge disc has come out, up migrated disc has come out in one piece. And this is now extrafemoral disc. This is a MRI of a patient. This is extrafemoral disc. These are the X-rays landing where you have to land. This is you are landed later to the pars here, and then you switch over to a saline mode to have a better clarity of that working area. So bleeding is very well controlled by RF. So it is very, very important for a surgeon when he's starting these techniques, whether dry or saline, he should have a good bipolar or a RF probe with him in the theater. Initial bone bite is taken at the isthmus, then undercutting of the isthmus. And finally, you can see the exposed nerve root. In the dry mode, I am trying to demonstrate. And this is a Cambin's area. Then you, with the pen feed, you try to retrieve the disc fragment and finally do a discectomy, and that completes the procedure. This is a facial cyst excision. I'll skip this slide. And now sharing with you instability. This is where I think the UV has come into a picture where surgeon is planning a fusion. So this is again a 72 years old male patient suffering from Parkinson's syndrome and disabling lumbar canal stenosis and instability. So this is initial triangulation, marking the levels, and then this is the outside working view. And once you are inside, you can see lamina is nicely exposed. This is a right-sided approach. Then you use a burr to burr at the base of spinous process.
The burring and bony work continued up to the proximal extent of the clever attachment. Then we burr on the opposite side and the base of the spinous process to create space on the opposite side also. This is the appearance of the phlegm. Now we are detaching the phlegm on our side. Laterally also, distally also, that is the limbs of the apical pad below there. This is we are attempting an end block removal of the phlegm with the help of a disc process. That is the dura completely seen below it. That is the picture of the end block phlegm removal. Now we are putting in patty to create more lateral working space that is traversing route, that is the disc below. We follow the middle wall of the pedicle proximally to gain access to the disc and do a rotary puncture with the help of this blunt pen field. We use a radiofrequency probe to open up the annulus defect. And this is the inside endoscopic view of the disc space preparation. under vision being done. That is how bone graft is packed into the disc space through a funnel insertion under vision with the help of a special nerve root retractor, which is again confirmed under serial imaging. That is how the cage looks in an AP and a lateral view. That is how it looks under the endoscopic vision once the cage has been data. And this is the final picture. That is a bit of a gel foam placed over the cage. This is the lateral side. Now we are going to the midline. That is the opposite side. The scope is virtually on the opposite side. This is our disc on the opposite side. Annulus preserved. And below that, at 9 o'clock position is the traversing route on the opposite side. And this is how the MIS pedicle screws are inserted in the standard view. Thank you.
So less is better, but that doesn't mean that we do an inadequate job at the surgical target. You have to do a maximal invasive adequate surgical procedure at the site of pathology. Although your approach is minimal, collateral damage is much less, which helps in the quick recovery of these patients. So post-op protocol in this patient is mobilization out of bed few hours after the procedure. They can have even sure in the evening because there are no sutures outside. We give a waterproof dressing which can be taken off 2 days after the procedure, and then wound is left open. And those who are sportsmen, they can resume their sports after about 6 to 8 weeks. Conditions are wrong level due to tear, nerve root injury, infection, recurrence. There are fluid-related complications such as high pressure epidural hematoma, headache and neck pain, and there are RF-related low temperature thermal injury direct related. So surgeons should be aware of all these complications so that to minimize or to avoid these complications. So since 2002, close to 5,000 plus procedures, and I have done procedures beyond discs and decompressions, and really endoscopy is now much advanced. What we started in year 2002 when only initial discs were done, then decompressions, and now we are doing advanced spinal procedures with the help of an endoscope. Complications are dural tears, discitis, nerve injuries, recurrence, and superior wound infection. And just a word about how to minimize learning curve in these techniques. Here, the experience and technical skill of individual surgeon is very, very important. Patience, perseverance, and temperament to work through narrow confines is very, very important. A surgeon who is not cut out for this, endoscopy is not endoscopy is not his cup of tea. During early learning, more time required for the procedure and complications counted will be little greater, but that should not be discouraging. And good idea to set longer operating time and have simple case selection during early learning curve. And if you are not comfortable continuing with the procedure, you can always convert it to open, and there shouldn't be any harm in that. So just 3 steps to learning are very, very important, which I always advocate. Visit a colleague, the procedure which you want to learn, then try your hands-on workshop, and then do a first surgery in your theater. So to summarize, dual spine endoscopy, that is arthrospine dual UV technique, can be used in dry, PSLD, UV, and UUE mode. Innovative sounding technique helps minimize UV learning curve, radiation, and excessive tissue RF ablation. Indigenous design, thus very, very cost-effective. Judicious fluid management ensures nil fluid-related complications. Thank you very much. Hello.
Yes.
Yeah, Rishi, Ortho TV, we are done with our session. So I think we can, I'll like to conclude the session once again by conveying my thanks to ASSI team, Bombay Orthopaedic Society, and Wess faculty for sparing their valuable time and making this session session educative, and thank you very much once again. PC, you would like to say something?
But that's it. Thank you very much for the arrangements of this session and recording, and thank to the ASSI team and the Bombay Orthopedics Association, Bombay Orthopedic Society, and I think we'll see you and meet you in the January. That's all. And thanks to
See you during
Dhira.
Jan
Dhira
ASSI meeting in
thanks to
Bombay.
Dhira Atman. Nice to see his face also. After long time, I am seeing him.
Yeah,
Nice.
sorry.
Yeah, thanks, Mukul.
Yeah, thank you, Dhira, for sparing your time and be with us. And we meet soon in Delhi. I hope you are attending West in Jan.
I will try to come to Delhi.
Yeah, Delhi
Yeah,
will
yeah,
be
yeah.
in
You must
February.
come, and
Delhi will be
you
in
should
February.
be sharing your experience and delivering a faculty talk also there.
Yeah, come. We'll see you.
Thank you,
Okay,
sir.
see you,
Right then.
Mohinder. Okay, thank you.
Okay, bye-bye. Thank you.
Bye-bye, sir.